Esophagus, presented by Dr. Mary Maish, Chief Thoracic and Foregut Surgery at Washington Hospital Health System. Please give a warm welcome to Dr. Maish.
Does everybody get to stand on this platform? Good morning. I'm going to give you 3 lectures, I think, and I am hopeful that I can give you some information that's going to be very useful for the exam. So I will, having taken the exam not too long ago, I can kind of remember some of the questions that came up in sort of a general sense. So if you have any questions, if you can hold them for the end, that would be great. And I will also be available at the end of all of my lectures to help clarify any questions you may have regarding the course material or just anything in general. And I always comment that, we're all colleagues. You have my email address. You're more than welcome to email me anytime with other questions that come up as you're studying, or even just, down the road in the future. If you ever remember, I think she might know something about this, maybe I'll email her about a patient and whatnot, and I may then count on you for a question of my own. So just keep that in mind. So we're going to start out by talking about the esophagus, and this will include lots of things about the esophagus, but the specific things about paraesophageal hernias are going to come in a different lecture, so if you don't get all the pieces to that puzzle in this lecture, don't worry, there'll be more coming later. So I have nothing to disclose here. So we're going to start out talking about reflux disease, moving on to motility disorders, taking a look at strictures, perforations, and leaks, and then finally looking at Barrett's esophagus and esophageal cancer. First question, all patients being considered for a fundoplication for reflux should undergo a pre-op testing with A, pH testing, B, manometry, C, an EGD, or D, all of the above. All right, so we'll get into this, but all of the above is the correct answer. When we're looking at patients with reflux disease, the workup tends to be critical mostly with respect to the tests that we're ordering. We're going to talk a little bit about the history and then the variety of tests that are available and which ones are very important and which ones are not as important to obtain in order to obtain the diagnosis. Traditionally, anyway, we used to talk about symptoms in terms of typical and atypical symptoms. The typical symptoms being those symptoms that we see patients that have this all the time: heartburn, regurgitation, bloating, and nausea. And over the years, the idea that these typical symptoms were the only patients would then be presenting with reflux disease has sort of waned, and the atypical symptoms have also become a lot more credible. So the respiratory symptoms, the repeated coughs or repeated pneumonias that patients can get are also now considered more typical. But traditionally, anyway, we divided them into typical and atypical symptoms. We also take a look at daytime versus nighttime relief, and then relief with PPIs. The EGD, we're mostly looking for changes of the mucosa, whether or not there's esophagitis or Barrett's. And the barium swallow, we're looking for anatomy. And then finally, we look at the pH probe with impedance to determine whether there's acid versus non-acid reflux, and then manometry to evaluate both the function of the esophagus as well as the pressure in the lower esophageal sphincter. A hiatal hernia is an anatomic defect that often leads to reflux disease. However, many people will not specifically have symptoms related to a hiatal hernia. It's where a portion of the stomach, or the fundus, or the top part of the stomach, is herniating through the diaphragm. A pH impedance is used to identify changes in the fluctuation of both the pH as well as in the pressures inside, or the flow inside the esophagus of acid and non-acid substances. And this diagram here gives you an idea of what a pH impedance study would look like, specifically looking at these dips here for patients whose pH is going underneath 4. You wouldn't likely be shown a graph like this on exam, but I think it's good to just kind of get an idea of how it looks. However, there are some manometry studies that may come up on your exam, and when we take a look at those, I'll try to remind you of which ones to take a good look at. The treatment of reflux disease, generally speaking, begins with medical treatment, H2 blockers, PPIs, and then recognizing that good candidates are patients that are usually responding fairly well to medications. That is changing a little bit now with the advent of some newer techniques in the treatment of reflux disease, including augmentation of the lower esophageal sphincter with a device, a magnetic beaded bracelet, that's called the Lynx device, that is put out by a company called Thorax Medical. And this device is slowly sort of coming into play in the treatment of reflux disease, but certainly would not be something we'd likely be asked on an exam. So traditionally, we still continue to treat reflux disease primarily with H2 blockers and PPIs. And then taking a look at surgical options, including a Nissen fundoplication, which is where the fundus is wrapped 360 degrees around, or fully around the bottom part of the esophagus to create a stronger valve and change that pressure zone, or a toupee fundoplication, which is a partial wrap where the fundus of the stomach is wrapped only partially, or about 270 around the bottom part of the esophagus to create a partial improvement in the pressure. And this is often reserved for patients that have slightly decreased motility. So if their esophagus doesn't have a good squeeze, we encourage people to consider doing a toupee fundoplication. The indications for surgery are not fast, written in stone. They are sort of fluctuating because we do know that patients that have typical symptoms, heartburn and regurgitation, will be good candidates. In saying what I mean by that is that if you were to then go ahead and do a fundoplication on them, they're likely to have an improved result. That doesn't mean that they'll have 100% success. That doesn't mean that they will necessarily be able to come off their medications 100% of the time, but they'll have a fairly good result in reducing or minimizing their symptoms. Patients with atypical symptoms will also are also good candidates or may have indications for surgery. So this would be patients with repeated pneumonias, maybe bad dental decay, some people with ongoing asthma or adult onset asthma. The difference here is that after you do a fundoplication on a patient with atypical symptoms, you may not see that immediate result. So we counsel patients to say, okay, if you have adult onset asthma and we find that you do have reflux disease, we don't then say, okay, we're going to go ahead and do your fundoplication and find that you're going to have immediate results. It's going to take time for that reactive airway disease to subside. So I would say that when you're thinking through an exam question and it may have something to do with like the results of the technique, you want to make sure you understand, was the patient treated for typical or atypical symptoms? Because patients with typical symptoms are likely to have an immediate result with coming off their medications quite quickly, whereas somebody that presented with atypical symptoms, it might take them some time before they can actually come off all of their medications, meaning they may still have to take their supplemental inhaler or some of their other medications to try to prevent ongoing airway or a reactive airway disease. The pH probe test, which requires a probe to be placed in your esophagus for 24 hours, has always been based on the Demeester score. And the average or normal score is 14.7. So I often get asked the question, well, what if it's 16? Okay, well, if it's 16, it's considered abnormal, but it's obviously not grossly abnormal, and it's not the only piece of testing that you're going to use to determine whether or not a patient is a good candidate. We're also going to combine that with an impedance score. So impedance, again, is measuring flow in the esophagus. So everybody has a normal number of impedance flow in their esophagus every day. In fact, that would correspond to the normal number of reflux episodes that we all experience. And believe it or not, even in normal patients, it's about 47 episodes a day. So Anything above that is going to be considered abnormal. So if you combine that with the new Demeester score, you're going to get a sense of whether or not this patient actually has a change in the flow, and if that flow of the reflux material is actually low in pH. A hiatal hernia is an indication because it's an anatomical abnormality that needs to be corrected. So there is no medication that's going to sort of help with correcting the anatomy. It may help with the symptoms, but not actually help with the anatomy. So generally speaking, we recommend an anti-reflux procedure for anybody who has a hiatal hernia, whether they're symptomatic or not. Of course, there could be some contraindications to that. So patients that have other debilitating diseases who may not have access to their hiatus for one reason or the other from previous surgery. But generally speaking, we recommend it for everybody. And then failure on medical treatment. So this is something that's a little hard to tease out in an exam question, but what we generally say is that if patients have had a good 6 months of maximized medical treatment and continue to have ongoing symptoms that are interfering with their activities of daily living, then we would recommend surgery. So we talked a little briefly about the different options, but just to sort of clarify some of the older context. Okay, so right now, if you think about the evolution very briefly about reflux, and 40 years ago, how the only medications we had were like, Maalox and Tums and Alka-Seltzer. And then on the surgical end of it, the only way that we could access the hiatus was through a big, midline abdominal incision or through the chest. There were really never very, very good options, so people just sort of lived with their reflux disease. And then when the advent of good medications came about, people were avoiding surgery because at that time, in the late 70s and early 80s, without laparoscopy, people, were offering medications to fix the symptoms and avoiding these still rather big operations. But then as time progressed and laparoscopy came into vogue, now all of a sudden the medications didn't become as, interesting, and they weren't as good because we could quickly fix with a laparoscopic procedure. And now we're kind of coming full circle because the medications are starting to show, some of the literature is starting to show that the medications cause some problems. So the PPIs can, have this link to dementia and cardiovascular disease and renal disease and osteopenia. So people are once again coming around to what else can we do to fix the reflux disease. And we have this new augmentation device that has been around for about 10 years and may or may not start to take the place of actually taking medication. But on the boards, when we take a look at what they're trying to understand what our knowledge base is, it's probably not about these extremes, the older times and the newer times. So it's basically down to just the lapnicin, which again is the 360-degree wrap of the esophagus by the fundus of the stomach, or the toupee, which is just a partial wrap done for people who don't have a really good squeeze in their esophagus. And then there's two other surgeries which would almost never be applied, but may appear on an exam so that you can at least understand what they are. The Belsey wrap is an old operation that was done through the chest. And again, it was just to wrap the esophagus partially around the bottom by the fundus of the stomach. But it's a very, it's a somewhat challenging operation to try to perform, and really is now only reserved for people that maybe have had some pretty already extensive work in the abdomen and really don't have access laparoscopically. And even then, most people are still going to just do a Nissen through the chest. And then the laparoscopic door fundoplication is an anterior wrap. It's actually just changes the angle of His just slightly in order to prevent reflux. That is really just preserved for patients that have had a Heller myotomy for achalasia. And we almost never have to use that for anybody that's coming with reflux disease. It wouldn't be enough. So when you're sort of sorting through the answers, which operation you might have to choose, or maybe something with regards to how these operations are done, the only two you really have to think about are the Nissen and the toupee. The other two you might see, but it's really just for historical interest. This is a little picture for you. The hot dog in the bun is the toupee, and the Nissen is the full wrap. And then again, you can see the door is this sort of flap valve over the top of the esophagus, and the Belsey is this more complicated invagination of the esophagus by the stomach, kind of coming up on the top of the esophagus there. The complications of surgery from fundoplication are a little bit evolving because of the improvement of all the techniques. So in general, we think of the complications being more related to aspiration from anesthesia and perforation from the bougie. But now that is greatly reduced because the techniques, we use the blunt bougies, and anesthesiologists, when they're putting these patients to sleep, will use rapid sequence and often intubate them when they're still a little bit in the upright position. So the complications are now focusing more on the surgeon, and that tends to be, did you wrap them too tight and now they have dysphagia, or did you wrap them too loose and the wrap is going to start to come undone? There also is a slip nissen where the nissen itself, the fundoplication, remains intact, but it slips back up into the chest. And that's not a complication of the wrap. That's a complication of failure to fix the hiatal hernia portion. So that wouldn't happen, for instance, in a patient that was going to surgery that didn't have a hiatal hernia. That would only happen in a patient who started out with a fairly sizable hiatal hernia. You went ahead and reduced it, but then the crura became unraveled and the hernia part of the operation failed. The complications in general we sort of look at is usually it's about 10% in 10 years. So you're going to have the chance of it either slipping, coming undone, or being too tight about 10% of the time in 10 years. So it's still a relatively good long-term fix for most people, but not without a possibility of complications. Okay, so we'll shift now from reflux disease to motility disorders. And one of the things that I like to remember as we shift over is that many of the symptoms, the presenting symptoms, can be the same, which is why it's important to sort of understand the differences in the way these two classifications of esophageal problems are actually teased out in the testing, because it's the testing that's going to allow us to understand what the actual disease process is, as opposed to the symptoms, which can often be the same. So the question is, what is the most sensitive manometric finding indicating achalasia? A, amplitude; B, lack of peristalsis; C, lower esophageal pressure; D, failure for the sphincter to relax. So the answer is D, failure for the sphincter to relax. And this will help us sort of understand some of the other abnormalities of the esophagus that will be put on the exam as sort of a red herring. But to remember that the most important piece of the puzzle for achalasia is the failure of the sphincter to relax. So you may not have an abnormally tight sphincter. You may not even have all the other classic abnormalities of the body of the esophagus, but you should see this failure for the sphincter to relax. There are a variety of other benign disorders associated with the esophagus, and this is like those things that you just don't want to have to remember, but you need to just at least become familiar with them, because most of them you're never going to see in practice, but on an exam, again, they're going to be stuck in there just to remind you, oh, did you know what, IEM is? And so I'm trying to give you a couple of buzzwords to help you remember things, and then focus mostly on achalasia, which is the very, very likely, to be seen in some capacity. So there are two tracings that you should try to know. The first is that of a normal esophagus, and this one particular tracing I included because it shows you how very difficult it can be to really line up the tips of all those waves. In order for it to be normal, you need to see progression, and the complexes are more narrowed, and there is at least a very small, minute amount of progression of those waves. So if you were to line up a piece of paper, now it's all computerized, so it's a little harder, but I used to teach the residents, just put the piece of paper down there and line it up. But if you can line it up, you can see that there's a minuscule amount of progression, and that would be a normal esophagus. So it's sort of the size of the amplitudes being a more narrow complex, and then a slight progression. And when I show you the one for achalasia, you'll see the distinct difference, and you commit those two to memory, and you should be good. Achalasia often presents with dysphagia, mostly in the mid to distal part of the esophagus. Okay, so people are going to feel the pressure in the mid part of their chest, and then that's where they're going to start to feel the pressure there, and then they're going to feel this release of pressure in sort of the bottom part of the esophagus. In the esophagus, if you have an obstruction in the mid portion of your esophagus, you're going to feel it like in the back of your throat. So remember, achalasia is a problem at the bottom of the esophagus, but they get mid-esophageal chest pain. It generally progresses from solids, and then they can't drink liquids. But very, very commonly, it presents with heartburn. And so sort of a classic thing, is to try to trick somebody into thinking that, oh, this patient has reflux disease, we're going to go ahead and wrap them. I can't tell you how many people I have come to my office, referred to me for heartburn, and they're like, oh, we're sending them here, we want them to get a fundoplication, and then I do the manometry study, and sure enough, they have achalasia, which of course doing a wrap on an achalasia patient would be a disaster. So just really remember that just because they're presenting with heartburn does not mean that they necessarily have reflux disease, but definitely more commonly they're going to present with dysphagia. The workup usually begins with a barium swallow, showing this classic bird's beak appearance, which I'll show you later. And then taking a look at the manometry, there are several things that you want to look for. But again, the most important thing is looking to see whether or not that lower esophageal sphincter is failing to relax. So it's retaining its pressure. So the normal pressure in the esophagus is about 15 to 24. And if we see a pressure, residual pressure that's higher than 15, for sure we know they have achalasia. And in order to, here I have residual pressure of greater than 5, that's sort of dependent a little bit on the testing, and they should sort of give you a normal range, so that you kind of know, because it's a little different on every manometry machine. But generally speaking anyway, any time that you're seeing a residual pressure above, it should be 0 or close to 0. You can be sure that they're retaining that pressure during swallowing. There are other things to look at as well. One is the esophagus itself is going to have no peristalsis, so you're not going to see that progression of the peaks of the waves. You're going to see this very low amplitude, so these complexes will be very wide. And then also the pressure of the esophagus is always going to be a little elevated over 0, because it's going to always be filled with air. So there's going to be some amount of pressure retained in the esophagus at all time. And then finally, the only role for endoscopy in achalasia, if you're suspecting somebody with achalasia, is just to rule out that they don't have pseudoachalasia, which is due to a mass. So same symptoms, but different pathology. You cannot tell on an endoscopy if a patient has achalasia, so it would not be a diagnostic tool that you would use. You can't pop through the lower esophageal sphincter and say, ooh, achalasia. No, you cannot tell anything. Many times it feels and looks very, very normal. The treatment has evolved. Again, back before the advent of laparoscopy, oftentimes achalasia was fixed through the chest transthoracically, so that a myotomy could be done on the lower esophageal sphincter, but also about 10 centimeters on the distal esophagus, because it was very difficult to perform that open and get up onto that esophagus about 10 centimeters. It was traditionally always done through the chest. Laparoscopically now, it's much easier to be able to get into the mediastinum, and we generally say, if you're going to do surgical treatment, that you're going to try to get at least 5 to 7 centimeters up into the esophagus. So the treatment of achalasia has changed accordingly. We have sort of moved away from pneumatic balloon dilation, which back when surgery was very difficult was one of the mainstays. And it actually worked pretty well for varied lengths of time. And then we've introduced also Botox, which also can work okay for a varied length of time. But these are neither one are going to be permanent fixes. In fact, we generally say within 2 years, both of them are going to fail. And you're likely going to need either repeated balloon dilation and or repeated Botox injections. They can be very good, however, for determining whether or not a patient is going to benefit from surgery. So sometimes a Botox injection in a patient that doesn't have a classic picture will help us determine whether or not a patient's going to move on and do well with a Heller myotomy. But I would say that it's probably not something that would be teased out really well in an exam. The answer to almost any question you're going to get on for the treatment of achalasia is going to be surgery. And this is also for the elderly. This is also for patients that are otherwise have many comorbidities. There's almost nobody who isn't going to benefit from surgical treatment of achalasia. So contraindications would be somebody who has like massive ascites from liver failure, or complex redo surgery on the hiatus. So there can be some people that may be contraindicated to have surgery, but otherwise age, other comorbidities are not considered contraindications. We generally approach it laparoscopically and then decide whether or not we're going to perform a fundoplication or leave the hiatus just open. And most of the literature leans towards doing a door fundoplication, again, sort of just that anterior wrap. It's just a small little change in the angle of His in order to prevent post-op wide open reflux, because now that we're cutting the sphincter, we're going to have wide open reflux. In my experience, I find that it helps about 50% of the time. So whether you do it or you don't do it doesn't seem to make a huge difference. But if you do it, at least you can say, well, I've done everything that I can, so all that's left for you is just to put you on medication. But the literature definitely does favor. So I would say, in general, err on the side of choosing the answer of a myotomy with fundoplication. Transthoracic myotomy is almost never done anymore unless somebody has a contraindication to abdominal surgery. And generally speaking, again, we have about a 10% failure rate at 10 years. It's almost always because of scar tissue that forms. It's not because of a failure of the myotomy. You probably performed a beautiful myotomy, but over time the scar is going to pull and bring that lower esophageal sphincter back together again. So here is the classic bird's beak appearance. You can see on the left-hand side, and then on the right-hand side, you can definitely see a distinct difference from that previous manometry reading that I showed you, where those peaks were nicely lined up in sequential progression, and they were narrow complex. And here you're going to see these wide complexed waves where the peaks are all stacked up on top of each other. So they just look like mountain on top of mountain on top of mountain. This is a classic tracing for achalasia. And I'm going to show you all the other tracings for the esophageal abnormalities just so that you don't get thrown off by them. But these are the only two I think you really need to know. Diffuse esophageal spasm is something that's generally not treated surgically, but it is something that a surgeon might see in trying to tease out what the problem is in the esophagus. In contradistinction to achalasia, which presents with dysphagia or heartburn, or contradistinction to reflux, which generally speaking is going to present with the typical symptoms of heartburn and regurgitation, or the atypical symptoms of airway disease, almost all patients with DES present with chest pain. So it's a very easy change in symptom. So you know that these patients don't have achalasia or reflux disease because they don't present with pain. These patients present with random chest pain. They also tend to be a little bit kooky in their head, so you kind of got that going for you. You kind of know, okay, there's probably something going on here. And the workup is usually once you do the barium swallow, you can kind of see this abnormal pattern, but the manometry studies, the esophagus looks fairly normal. You're going to otherwise look at it and say, well, this doesn't look too bad, except for one thing, and that is the presence of tertiary contractions. We have primary, secondary, and tertiary contractions in the esophagus, and you don't really need to know anything about them, except for to know that tertiary contractions are abnormal because they allow the reverse peristalsis, and they're random. Primary start from the mouth and go down. Secondary are started in the middle of the esophagus and propagate down. And tertiary contractions are sort of randomly propagated up and down. And so in DES, this is what we see on the manometry studies. And when I show you the picture, you'll see what I mean. The treatment is all medical: nitrates, calcium channel blockers, anxiolytics, and alternative therapies. Generally speaking, that's what we recommend. Surgery never helps people with diffuse esophageal spasm. You can see here it looks like a colon. If you see this classic pattern of DES, it looks like haustra. And then on the manometry study, you can see here that there are amplitudes that are propagating in the opposite direction. Very similar to DES, in fact, oftentimes now lumped into the same category of just esophageal spasm, is nutcracker esophagus. So again, it's also going to present with chest pain, not reflux, not heartburn, not regurgitation, not airway symptoms, not difficulty swallowing. It's going to present with chest pain. Some people may have a sensation of food kind of passing slowly through the esophagus, so sometimes that's a surrogate for dysphagia. But most of the time, people are going to present with chest pain. And again, the workup is going to be classically seen on a barium swallow, but more specifically on the manometry, we're going to see these super high amplitudes of these individual waves. So if you see this, it's unmistakable. This does have, there is a role for surgery in treating patients with nutcracker esophagus. It's a long myotomy, or sort of what we do for achalasia, but just a much longer segment of esophageal muscle that's divided. It has varied success, but in patients who have really difficult, really bad symptoms, you can try it. Botox is usually used in an effort to see if these patients are going to benefit from surgery. So again, Botox is sort of has a limited value, but can often be very helpful in determining if a patient's going to benefit from my myotomy. So doing multiple Botox injections in the lower third to half of the esophagus, if they get symptom relief from this, then you can say, well, they might benefit. And if they don't, then you wouldn't want to bring them to the operating room. Here you can see the corkscrew nature, so different than, it doesn't look like haustra in the colon, right? It looks more like a twirly slide in a kid's pool. It's a corkscrew appearance. The manometry has these really high peaked waves here that run over the top of the other tracings. This is classic for nutcracker esophagus. Ineffective esophageal motility is it's one of the newer esophageal motility disorders. The only thing you really need to remember about this is it's associated with reflux disease. So it may be something that's included in when you're having a question about reflux disease. So very commonly patients present with sort of these lower amplitude esophageal waves in the bottom part of the esophagus, or perhaps they may not actually propagate or peristalse all of their waves, right? So in normal esophagus, good amplitudes, good progression of peristalsis. In IEM, you're going to see mostly good amplitudes and mostly good progression, but you may not see perfect progression or peristalsis up to about 30% of the time. So in these patients, they're commonly on their pH probe, you're going to probably find reflux disease. Probably going to be refluxing acid, and you'll find that on your pH probe. And the treatment is just to treat their reflux. So you either treat it with medicine or you do surgical treatment. And even though their amplitudes might be low, or even though they may have some ineffective peristalsis, they still have enough that you can still do a full 100% Nissen fundoplication. So this is kind of a common question that I get. Well, what about if you have somebody that has IEM? Are you going to be able to do a Nissen on them? Yes, you will, because most of the time they have enough squeeze to be able to squeeze beyond that full wrap. You really only have to do toupees on patients that have significant changes in their motility. Somebody, for instance, with scleroderma who's presenting with airway symptoms or repeated bronchitis. Those kinds of patients with sort of underlying connective tissue disorders that have known esophageal motility problems are more likely going to get a toupee. But somebody with IEM can get a Nissen fundoplication. And then the last esophageal motility disorder to just sort of understand and know about is this non-effective esophageal motility, or NEM. And it's a wastebasket for all the things we don't really know. So, you get a little bit of this, a little bit of that. It doesn't fit into any classic pattern. You call them an NEM patient. You don't need to know anything about it. You would never perform surgery on these patients. There's no medical or surgical treatment, really. It's just something that are sort of troubleshooted on an individual basis, but you may see it. Okay, so that's motility disorders sort of in a nutshell. I think, again, sort of to recap, if I had to reach back and say what are the important things to remember, typical versus non-atypical symptoms are important because oftentimes it's the way that it's addressed. Understanding the difference of when you're going to use a Nissen versus a toupee fundoplication. And then when you're talking about achalasia, it's the failure of the sphincter to relax, often presenting with heartburn, and an esophageal myotomy is the treatment of choice for almost everybody that comes through the door. So kind of think about that. And then the two manometric chasings to try to take a last glimpse at sometime is the achalasia and the normal. And I think if you get those, you're likely to get just about everything you might get asked. Okay, we're going to talk about strictures and perforations and leaks. They all kind of blend together a little bit, somewhat treated pretty similarly. So hopefully this will help clarify any questions you have about it. So question, a patient with a small contained esophageal perforation can be observed if the following criteria are met. A, less than 2 centimeters. B, mediastinal pleura are intact. C, patient remains stable. D, all of the above. And the answer is D, all of the above. We'll want to distinguish between a benign and a malignant stricture because it does definitely change a little bit on how we're going to approach the patient. So the benign strictures are generally from, and most commonly anyway, from reflux esophagitis, and these patients need to be dilated and massively acid suppressed, and then some sort of surgical reparation to try to prevent ongoing damage to the lower esophagus. Generally speaking, you would not want to dilate these patients and then place a stent in them and then cause more wide open reflux across the GE junction. So somebody who's suffering from a benign stricture in the distal esophagus from reflux esophagitis would not benefit from placement of a stent. A caustic stricture, however, is going to be dilated pretty immediately after the injury, and then a temporary stent may be placed and removed and replaced and removed as the patient progresses through the first 6 weeks to 3 months worth of post-caustic repair. If a patient then has to go on to have surgery, it's going to be based on where the remaining strictures occur and whether or not their stomach was affected at the same time, because a lot of times when people are drinking the caustic substance, it also damages their stomach, so it's not available for interposition. And finally, if you're looking at a benign stricture that's caused from an anastomotic leak, these patients can be dilated, and over time, more likely than not, just dilation is going to be enough to help. But a patient can also be, a stent can also be placed, but again, you would not want to put it across the anastomosis if that's going to increase some sort of wide open reflux, because patients will have a lot of symptoms from that. So that's very different than when you're treating a malignant stricture, where you're going to go ahead and gently dilate over a short period of time, small intervals of improvement, because if you dilate and you perforate, then you have to take that patient to the operating room, very difficult to manage. So as opposed to a benign reflux stricture where you've got a little bit more leeway, in a malignant patient, you're going to do multiple small dilations, and then you can place a permanent stent. And even in a patient that has a GE junction tumor, for instance, you can go ahead and put that permanent stent and then massively acid suppress them to try to prevent symptoms, but you don't have to really worry about whether or not they're going to go on to have, more esophagitis, because it's probably a temporary end-of-life sort of measure. So you just need to be able to control their symptoms. So in that patient, you can go ahead and stent right across the GE junction. When we're talking about perforations and leaks, we sort of think a little bit similarly to one another, because they're for the most part, the thought process is about the same. We're looking at location: cervical esophagus, mid-esophagus, distal esophagus. Is the perforation contained? Is it flowing into the pleura, or is it staying put in the mediastinum? So you got to think about the anatomy a little bit. Is it big or is it small? So generally speaking, less than 1 centimeter, pretty good to watch it. Is it 1 to 2 centimeters? You got to look at the patient. Greater than 2 centimeters, probably not going to heal on its own. Time frame: did it just happen? Did it happen 2 days ago? Did it happen 2 weeks ago? Tissue viability: is it still healthy? Is the tissue still able to be reapproximated? Is it going to heal on its own? Is there a distal obstruction from a tumor or achalasia? Right, achalasia is a distal obstruction because of the increased pressure zone below the area of perforation. Is the patient sick, or are they looking pretty stable? Same thing with leaks, okay? Basically the same thing. The only thing you're going to add in is the graft viability, is the conduit that you put in or the two ends that you sew together. Are they viable, or has there been a significant compromise in either the venous outflow or the arterial inflow? But otherwise, we like to think about them the same. So the controversy always comes with respect to, do you scope them first or do you do a swallow study? So on the exam, you're always going to put that you do a swallow study first, because traditionally that's always what we've recommended. And the reason is because as we invented this new thing called endoscopy, 35, 40 years ago, in the beginning it was kind of crude and it wasn't finessed. But now, you can easily finesse an endoscopy where you can go in and take a good look at exactly what you have. So in practice, many of us are just going to go right in with an endoscope if we think that we have a perforation. But, maybe you don't do that. Maybe you don't know somebody who can do that. Maybe you don't have any GIs that want to take it on. And on an exam, you're not going to have any of that. So just get a barium swallow. Now, the next question I always get asked, is it barium or is it gastrografin? Okay. It doesn't really matter as long as you don't think the patient's at risk for aspiration. Okay. So if the patient is wide awake, doesn't really matter. Okay. If the patient is kind of sleepy, you don't want them to aspirate gastrografin. You don't care if they aspirate barium. So just remember that gastrografin is caustic to the inside of the lung. It doesn't matter if it goes to the outside of the lung. It's the inside of the lung that it's caustic to. So if you have a risk of aspiration, just use barium. If you're not sure, choose barium. It's probably the safest answer, but try to think about it. The other thing is a little bit about the evaluation of the location. You need to be able to distend the esophagus enough in order to determine if there's a leak. So you can imagine if there's a small hole in the esophagus and you just give your patient a few little sips, it's not going to probably show anything. So if you really want to have a good diagnostic study, there has to be a pretty good volume of barium. And so most of the time, if I'm doing a barium study, I'll ask them to do a dilute barium, because that way they're drinking a lot more volume with relatively less barium stuck in places that you might have to operate. So start with a barium swallow and see how that goes. If you can localize the injury, you don't actually have to do an endoscopy to look at it unless you think that you're going to go in and repair it. Then I would say you need to go in and take a look endoscopically, because if you're looking at a graft, for instance, you need to take a look at the mucosa and see whether or not there's enough viability left. You can't tell that from a swallow study. The other thing is the size. If you can see the size fairly convincingly on the swallow study, you're okay to quit there. But many times on the swallow study, unless you really expand and drink a lot of barium and you expand that esophagus, all you can see is whether there's a leak or not. You often you sort of underestimate the size of the leak itself. So the endoscopy is really good for evaluating the size. And then finally, sort of evaluating the edges. Are they tattered? Is it a clean cut? Those kinds of things are difficult to glean from a swallow study, but are important to gain from an endoscopy. So if you get the swallow study and you're not sure of what you're seeing, then you need to move on to an endoscopy. If you're pretty convinced of what you're seeing, then you don't need to. The next thing we want to take a look at in the perforations is where's, again, neck, chest, or abdomen. It's going to help us determine whether or not we're going to need to proceed to the operating room. A leak or a perforation of the chest is much more likely to need surgical intervention than one in the abdomen or the neck, which can be very easily drained. The next thing we take a look at is it contained? If it's contained in the mediastinum or contained in the neck or contained even in the abdomen, those patients, generally speaking, don't ever need to go to the operating room. They can be drained and observed on antibiotics. But if they're not contained and they're floating all over the abdomen or all over the neck or the pleura, then those patients are going to have to go to the operating room. And then again, we talked about the size. Generally speaking, 1 centimeter or less, you probably can get away with no surgery. Usually greater than 2 centimeters, pretty difficult to manage. Sometimes you can, but pretty difficult to manage. Might take a long time. I mean, I have managed 3 and 4 centimeter esophageal perforations that are contained on patients, but I tell them you have 2 options. One is we go to the operating room and we open up your chest and we open up the mediastinum and we clean everything out and then sew you back together and you'll be better in 2 weeks. Or in 6 weeks, with conservative, peg tube conservative management. So kind of depends on what somebody wants. But generally speaking, anything greater than 2 centimeter, it's going to take a very long time. Also, the time frame. The sooner you get to the injury, the better chance you have of being able to do a primary repair. It's not a fixed rule. It's not like somebody who perforated 72 hours ago couldn't be primary repaired. They could be. Maybe their muscle edges are going to be nice and clean to sew back together. But it depends on what it looks like at the time of surgery. Muscle flap. When do you place a muscle flap? You place it any time that you're not sure about your repair. It's not related to the time frame, but generally speaking, after 48 hours, the chances that you're going to have clean edges that you're going to sew back together as a primary repair and not have to put a muscle flap are pretty low. So that's why, as a rule of thumb, on an exam, you're going to kind of use that 48-hour as a cutoff for when you would absolutely want to place a muscle flap. But if they said something like, you get into the operating room and there you are, and it's a lot of inflammation and it's only 24 hours, you're going to place a muscle flap on that patient too. So it's not a steadfast rule. Tissue viability, if it's clean, the edges are nice and clean, and it's not there's not a lot of debris that you'd have to debride and then create even a bigger hole. Clean repair, a clean incision or perforation, you're going to be able to repair primarily. Otherwise, try to repair it, place a muscle flap. Distal obstruction, almost always, if you have a distal obstruction, you have to relieve it. So if it's an achalasia patient, you do a myotomy. If you have a patient with a tumor, you're probably going to do an esophagectomy because you need to take it out anyway. Other things from like foreign body, an obstruction from a foreign body that causes a perforation, you may have to do a diversion because it may cause significant damage enough to the esophagus where actually trying to primarily repair it could be very challenging. And then finally, you're going to look at the patient's clinical condition. I mean, if they're stable and their white count is, and their vital signs are all indicating that they're handling this acute episode well, you can continue to observe them. Even in the case of a freely perforated patient with a small collection in the pleura, you could go ahead and put a drain in that, observe them on IV antibiotics. But as soon as they become sick or unstable, then you're going to take them to the operating room to repair them. So this is all the same from perforations and leaks as well. So if you have a post-op patient that's had an esophagectomy, you're going to treat it the same thing. You're going to take a look and see where is the location. If somebody leaks in the neck, you open the neck. If somebody leaks in the chest, you can sometimes place a drain in it. Very difficult, but sometimes with our newer IR techniques, you can do that. Or you're going to have to go back in and primarily repair and or place a muscle flap. Abdomen, same thing. Might be able to place a drain just under the diaphragm and heal that perforation, or you may need to go back to the surgery if it's freely contaminating the peritoneum. Again, now you have graft viability to take a look at. If it's not viable, you got to go back to the operating room and take it out. And again, the time frame. Same thing when you're looking at leaks. If you're looking at an anastomosis, generally speaking, a technical problem is going to occur, just like with any other, vascular anastomosis. A technical problem is going to occur usually within the first 24 hours. So you're going to want to take them back to the operating room to fix that. Make sure it's adequately drained, and then be ready to take them to the operating room if their condition changes. Okay, so we're going to shift a little here now to Barrett's esophagus. Barrett's esophagus is not something we encounter very much as surgeons, but we do get asked about it because we often have patients who come with a diagnosis of Barrett's when we're treating them for reflux disease or some other esophageal condition. So I think the most important things to know about Barrett's are mostly just the different phases of Barrett's and then also the intervals in which you would be recommended to follow up. So the question is, when should a patient with a finding of Barrett's esophagus at initial EGD be scoped again? A, 3 months, B, 6 months, C, 18 months, or D, 1 year? And the answer is B, 6 months. And I've got a nice chart for you so that you can sort of remember when that interval is. So there are a couple of important things to remember about Barrett's. And again, this is changing a little bit because of technology, but In order to have a diagnosis of Barrett's, the endoscopist has to see it, and the pathologist also has to confirm it. So just because you think you see it and you take a biopsy and it comes back on the pathology as not Barrett's, it's not a diagnosis of Barrett's. And the same is true and vice versa, right? So you both, the pathologist and the endoscopist, have to see it. And the reason for that is because if the endoscopist were to take a biopsy closer to the cardia, let's say, it may show changes that look more consistent with Barrett's esophagus, but wouldn't actually be Barrett's. So it's very important for the endoscopist to think that they see it, document the location, and then the pathologist to actually see the goblet cells inside the specimen in order for it to be considered Barrett's esophagus. There is Barrett's metaplasia, which is just the initial changes seen in Barrett's esophagus. Then there's low-grade dysplasia, where the DNA strands become disorganized, and then the high-grade, where it's even more progression. We used to say that if you had high-grade dysplasia, you had about a 40% chance of already having adenocarcinoma, and that was not too long ago, actually. But now we know that that's probably not so true, because we have much more advanced techniques to diagnose high-grade before it goes on to become adenocarcinoma. But nonetheless, high-grade dysplasia still has a very high incidence of progressing to adenocarcinoma. As the only way we can diagnose it right now with any kind of regularity is through an endoscopy and multiple biopsies. There is a new microscope that can be placed through the endoscope that can look directly at the cells and help us visualize where the disorganized cells are, so we can pinpoint where to take our biopsies from. And the visualization of this is so good that actually now we can just take pictures of it and send it to the pathologist, and they can agree or disagree with us with regards to whether or not it's Barrett's. So I would say that not too far in the future, it won't be necessary to actually perform a biopsy. All we'll actually have to do is just go in and take a bunch of pictures with this microscope of the bottom part of the esophagus, or wherever you think the Barrett's might be, and then the pathologist will be able to confirm whether or not there are actually any abnormal cells there. But right now, the only way to do it is through endoscopic biopsy. The best way to treat Barrett's is to treat the reflux disease, because most of the time, not all the time, but most of the time, people that have Barrett's disease have an association with reflux disease. And we don't know, although we suspect, that it's probably more likely due to the bile component of the refluxant than to the acid. But there's no doubt that once you have Barrett's, that the chronic exposure to acid can cause progression. So, you know, as an initial step anyway, treating patients with reflux disease will help to treat their Barrett's. There's also ablative therapy, which is recommended for low-grade and high-grade. And if you treat regular Barrett's metaplasia with ablation, so there's two types of ablation, that's radiofrequency, RFA, or cryoablation. If you treat with either one of those, you're going to see about 70% of the time that the Barrett's will actually go away. So there is a fairly good, resolution. Not quite 70%, but still reasonable to try to get your Barrett's to disappear. The problem comes in if you do that. Some people are going to progress to have what we call buried glands, and that is where the surface of the mucosa looks normal and might change to normal squamous epithelium, but underneath the glands are going to continue to progress. So there is this controversy as to whether or not you should ever treat just Barrett's metaplasia. So some people always do, and some people never do, and some people fall somewhere in between. For the purposes of the exam, I would say that the mainstay is probably still just observation with repeated surveillance and treatment of their reflux disease, because the other is still controversial, but you should at least know that it's a possibility. And then surgery. Okay, so surgical treatment is something that we used to always recommend for high-grade dysplasia and or for patients with long segment disease. So 2 centimeters or less, we could control endoscopically by doing surveillance. But then once we got into very long columns of Barrett's, doing that very aggressive surveillance is very difficult. And, most people get bored after a while. They're like, I've taken so many things. Okay, we're done. So they don't do a really good surveillance job. So surgery was recommended for patients with long segment and high-grade dysplasia. But now we have, improved techniques of trying to treat Barrett's. So patients with high-grade dysplasia can be treated with ablative therapy, or if they have a raised lesion, they can actually be treated with EMR, or endoscopic mucosal resection. So who would be a surgical candidate? It would be patients still with long segment Barrett's who may have a focus of dysplasia somewhere in there that's pretty hard to go back and find, or people who have flat lesions that can't be easily relocated endoscopically and then treated with mucosal resection, right? Because if you can't really see exactly where that lesion is, it's hard to inject the saline underneath to create a raised lesion to then go ahead and do that mucosal resection. However, now with this new microscope, we're going to be able to do really well-directed treatment of Barrett's. So we'll be able to go in, find it there, find the abnormal high-grade dysplasia, maybe tattoo it, and then go ahead and do mucosal resection. So it's on, maybe another couple years it'll be on the research, but probably right now. Surgical treatment for high-grade dysplasia is still an option for patients that have long segment or raised lesions, but otherwise we're going to, or flat lesions, but otherwise we're going to recommend EMR, or endoscopic mucosal resection. So here's the little table to help you remember for Barrett's surveillance, whether or not they have dysplasia, how often you're going to want to go ahead and repeat their endoscopies, and when their follow-up is going to be. So you can, take a look at this, and you can see now for high grade, the follow-up is going to be endoscopic mucosal resection, followed by surveillance every 3 months until you're convinced that it's gone. And so if you start out with low grade and then you're able to eradicate it, then you can fall down into the non-dysplastic category and continue on with the documentation and the follow-up in that category. You don't continue on a more abbreviated surveillance program. You can, once you fall into that category below you just follow the recommendation in that category. So we know that Barrett's esophagus can lead to esophageal cancer, and so with that, we'll sort of liaison into the next topic here. The question is, which stages of esophageal cancer should be treated with neoadjuvant chemotherapy? A, stage 1B, 2, and 3. B, stage 3 only. C, all stages. D, stage 2A, 2B, and 3. So the answer is stage 2A, 2B, and stage 3. And the use of radiotherapy, is also a little bit controversial in esophageal cancer as to who gets it and who doesn't get it. And there have been some more recent studies that are helping us with that a little bit, but I will try to give you a little bit of guidelines there so that in case you get asked on that, which I don't think you would, but in case you get asked on that, you have some background. We know that there are basically 2 types of cancer that occur in the esophagus. Adenocarcinoma is by far the most common in the United States, but worldwide, squamous cell is still more common. So hopefully that won't get you tripped up. The adenocarcinomas that we see now tend to be lower esophageal or GE junction tumors associated with, mostly, very commonly anyway, overweight or obese individuals who have had a history of reflux disease that has been treated, but not necessarily properly surveyed. And in many instances, patients also have Barrett's, but not always, not always. Squamous cell tumors of the esophagus are like any other squamous cell tumors, commonly associated with tobacco products. The demographics of adenocarcinoma are changing a little bit. It's becoming a little bit more common in the non-white male and also just in women in general. I mean, in my practice, I would say that I see almost as many women now with it as men, but it might just be where I live, because it's certainly not true across the United States. But it still continues to be one of the fastest growing cancers in the United States. Still relatively low numbers, maybe 15 or 16,000 cases diagnosed a year, but one of the most rapidly climbing cancers. And the other unfortunate thing about it is that most of the patients who are diagnosed in stage 4, so we don't generally tend to see patients in the treatment phase. And that is mostly just because the esophagus can distend or become narrowed to about 50% of itself before we have any symptoms. So your esophagus, which normally measures about 20 or 2 centimeters in diameter, has to get down to about 1.2 centimeters before you're going to notice anything, right? So you can have a fairly sizable tumor before you have any symptoms. And that's also true of patients that have dilated esophaguses, right? They can have dilations of up to like 3 centimeters or so before they even know there's anything different going on. So the capacity of the esophagus to change is pretty dramatic before we have changes in our brain, so that's unfortunate. Symptoms are classic. Almost always it's, long history of reflux disease that was treated but not properly surveyed on PPI therapy, come in with dysphagia and weight loss. The workup, again, often starts with a barium swallow, just because traditionally people were worried about instrumenting patients with dysphagia, although that's not so true anymore. You can go ahead and just do an endoscopy and get a diagnosis all at the same time. We don't generally put stents in as initial treatment. We try to gently dilate, mostly because if you put a stent across the GE junction, where many times the stent has to be placed in order to adequately expand the distal esophagus, patients are going to get wide open reflux and be extremely uncomfortable during their therapy. Endoscopic ultrasound is used for evaluating the T stage. It can be it's very operator dependent. When I was the director of esophageal stuff at UCLA, I just evaluated our own endoscopists, so I always felt we're very, very good. 30% of the time they were right, 30% of the time they were wrong, or over-called it, under-called it, and the other 30% they were dead on. So I think it's very operator dependent. It's also very difficult sometimes in a strictured area to be able to pass this big probe to try to evaluate the T stage. And to get biopsies and everything is also very difficult because oftentimes you have to go through the tumor to try to access a lymph node. It's not critical. The most important thing in esophageal cancer is to take a look at the obstruction of the lumen. You know you're not going to have an early stage tumor that has any obstruction of the lumen at all. These are very small raised lesions, these T1 tumors. They very quickly are going to fill the lumen if they go anything beyond the mucosa. But again, it's something that we often recommend getting in an effort to try to accurately stage somebody. More importantly is the end stage, because the end stage is really going to help us determine whether or not, what kind of approach we're going to have to surgery and whether or not we're going to think that chemotherapy is going to be beneficial. Unfortunately, the end stage is very difficult to obtain. PET scans are not great in esophageal cancer. Generally speaking, we have about a 30% failure rate in detecting lymph nodes in esophageal cancer. So we don't have a great way to understand end-stage disease. And then finally, M-stage, just like anybody else, just get a PET CT scan. Pretty good for looking at that. This CT scan here can show you how sometimes all you see is just this thickening. You don't really see a mass per se, just sort of a thickening. And then PET scans, you can see how it just lights up here in the middle of the esophagus. On an endoscopic ultrasound, you're going to see this thickened area here with this broadening of one of the concentric rings. And on the barium swallow, you're going to see sort of that classic apple core lesion, although I've never really thought it looked much like an apple core, but anyway, some of my forefathers must have. When we take a look at esophageal cancer staging, it's very easy. Stage 1 is T1, stage 2 is T2, stage 3 is T3. There are a couple of small exceptions to that you really don't need to memorize. It's so easy to just remember T1, stage 1, T2, stage 2, T3, stage 3. The end stage only becomes important in later stage 2 disease. It's very similar to so many other cancers, right? So early stage 2, 2A, is just an increase in the T stage, but not an increase in the N, so no nodal disease. And then stage 2B would be increasing it with the end stage, so you're going to have some lymph nodes. We also count lymph nodes and classify lymph nodes differently based on the number of lymph nodes. Just so that you know that, it's not important. All you need to know is if they have lymph nodes positive or not in order to determine the treatment, which is the only thing that you need to worry about for an exam. The other aspects we do for prognostic indicators mostly. I thought that this would be helpful because I don't think that many people remember that the esophagus is like the rectum. It only has 2 layers. So it doesn't take long for the esophagus to bust out, for the tumor to bust out of the esophagus and start to travel around. It also gives us a little bit more of a reason to be aggressive about early stage tumors. Okay, so you might, in other areas where we might be, like as in breast conservation surgery as an example, we're not so quick to jump on the esophageal conservation surgery route because it only has 2 layers. Having said that, we are making a lot of progress with conservation, esophageal conservation surgery, meaning endoscopic resection. But still, it's iffy because you can see very quickly that it doesn't take long before you're going from a stage 1 into a stage 2 by increasing just a couple millimeters into that muscularis mucosa. So the early stage diseases are divided into T1A and T1B. T1A is just up to the lamina propria, and T1B is full on to the submucosa. So now why do we bother distinguishing? In esophageal cancer, again, because we only have 2 layers, we kind of look at this as like our 3rd layer, right? So the lamina propria creates a barrier beyond which there's the neurovascular bundles that are running through that submucosa. And so before you break into that layer, into the true submucosa, you have almost a 0% chance of having any lymph node metastases. But once you bust into that submucosa, it goes up to almost 50%. So, it's huge in esophageal cancer, and that's because the plexus is extremely rich. So some people even argue that in T1B lesions, because of this, if you have a deep submucosal tumor that's butting up against you, but maybe not quite breaking into the muscularis, you may want to consider doing chemotherapy because the richness of that plexus and the chances up to about 50% of having lymph node metastases is pretty high. And then once, of course, you break into the muscularis, it's a T2, and then we call this adventitia, which is just a loose sort of connective tissue. It's not a real layer of the esophagus, but it's still very resectable, not into any adjacent organs. We call that a T3. And again, here's the kind of the counting of the lymph nodes. You don't need to know that for any kind of exam purpose, but just to understand that we're looking at, the extent of the disease based on the number of lymph nodes positive. And then we also look at M disease based on the lymph node location. Okay, so M1B is like if you have, a met to your brain or a met to your lung. Okay, so that's considered not resectable disease. But we used to have this idea that a celiac lymph node would give you a very bad prognosis. And that might be true if you have cervical esophageal disease, right? Because that would be considered quite distant. But if you have distal esophageal disease, the chances that you're going to have a positive celiac lymph node are pretty high. And that is no longer considered a contraindication for surgery. So you have to know where your lesion is to understand that if the celiac lymph node is positive, you still may be able to resect M1A disease, okay? If you had a mid-esophageal lesion, it would be considered regional disease, maybe not resectable if the tumor was really big, and certainly for a cervical lesion, it would be considered metastatic disease. Here's a nice algorithm that you can look at. Stage 1 disease, if it's a T1A lesion, we're going to try to do minimally invasive endoscopic techniques, mucosal resection. If it's a T1B lesion, we're going to recommend surgery at this point, although that's probably going to change at some point, but right now we're recommending surgery. A stage 2A lesion is going to be surgery alone. A stage 2B lesion, we're going to recommend definitely some chemotherapy ahead of time. And stage 3 lesions, probably chemo and radiotherapy. And here's another way to look at it, which is just a little bit more specific. The most controversial one is the stage 2A lesion. Neoadjuvant chemotherapy is gently recommended, but not strongly recommended because the lymph node contamination is not known, right? If you have a stage 2B lesion, it means that you know ahead of time that you have lymph node disease, so you're going to strongly recommend that neoadjuvant chemotherapy. And again, radiation is not well understood in esophageal cancer, so I don't think that's something that you're going to be asked to choose between chemo versus chemo with radiotherapy. But I would say, to be safe, anything 2B or greater, you can do chemo radiotherapy and it's probably going to be just fine. But the 2A is the most controversial thing in esophageal cancer right now. What do you do with a 2A patient? Do you just take him to surgery? Do you give him neoadjuvant chemo, or do you give him neoadjuvant chemo radiotherapy? There's so many other things to look at in that patient, how well they're doing, how much weight they've lost, whether or not they're going to be able to sustain aggressive neoadjuvant therapy. So I would say, in general, err on the side of middle of the road, just giving them chemotherapy. And again, another chart. Okay, so esophageal cancer has a lot of different surgical options because they can be located in different places. And there's different things that you're trying to achieve. So I always try to think about, first of all, do you have a patient that you're going to you're going to do surgery for cure, but you kind of know that they're not going to be able to withstand a big operation. So you have to keep the patient's clinical condition in mind. The next is the location of the tumor. And then finally, how much of that regional disease are you trying to control, right? So if you have an early stage 1B patient, right, you probably don't have much regional disease to control. But if you have a stage 3 patient, you've got a lot of regional disease to control. So you've got to think about that, unfortunately. The transhiatal approach is the easiest one for most patients to tolerate. So it's the one that you're going to put your elderly patient through, or your patient that's really clinically deconditioned, doesn't tolerate their neoadjuvant therapy very well. You get a very good local control for most patients, even patients with it was a T3 lesion, but not very good regional control, right? Because you're coming into the abdomen, you're just kind of like blindly grabbing what you can, and I mean, you can really finesse the lymph nodes if you get really good at it, but generally speaking, it's not quite as specific, right, as actually going into the chest and looking at the lymph nodes and looking at all those stations and grabbing them all, right? It's kind of a more blindish thing. So you can get good local control in most locations, but pretty poor regional control. But you have a pretty low leak rate, and when it does leak, it leaks into the neck because the incision is in the neck and in the abdomen, and so therefore the morbidity associated with it is pretty low. The Ivor-Lewis is where you then have to also make an incision in the chest. Now this can be done videoscopically, which helps the complication rate from the standpoint of patients going home. But in terms of the leak rate and everything, it doesn't change it. So it still has a slightly higher leak rate, and the morbidity associated with having a leak is also a little bit worse because a leak in the chest can be pretty grave in some patients that are on the cusp of being able to tolerate this pretty dramatic surgery. But the benefits are that you really get great lymph node control, right? Because you're in there and you can get really good control of the lymph nodes in the chest. And then finally, the three-hole or the en bloc operation, where you get an incision in the neck, incision in the chest, and also in the abdomen. I mean, this is the Cadillac of all operations. It can all be done minimally invasively, and you can get access to all the lymph node basins. So it would be ideal for somebody who has a large tumor or a mid-esophageal tumor that's going to have lymph nodes spread in both directions. It's not going to be good for your elderly patient with a lot of comorbidities, right? So you're going to have to sort of take those risks and benefits. It also has a fairly high leak rate because you're extensively skeletonizing the lymphatics, which causes a lot of shifts in your post-operative hemodynamics, and that increases the chance that your graft is not going to be as viable, and a slightly higher morbidity rate, mostly from aspiration pneumonia. So You kind of got to look at each patient. If every patient could tolerate a 3-hole or an M block, you'd probably send everybody for that in order to get good regional control, because right now we don't have great options for regional control in esophageal cancer. And chemo's not great. We don't have great techniques for identifying it. We don't really know what the stage of most of our patients are going into the operating room. We sort of have this, EUS that gives us a loose approximation, and the PET that's just horrible. So we kind of don't really know. So in choosing an operation on an exam, you got to look at where the location of the tumor is, how aggressive the tumor is with regards to the stage. The more aggressive the stage, the bigger operation you're going to want to give them, and then finally the patient, whether or not you think they're going to be able to manage a bigger operation. This gives you a nice idea of how things, where the incisions are going to be, and the increase in the leak versus the morbidity, and also then the regional control. So you can see the transhiatal, the incisions are in the neck and the abdomen, the anastomosis is in the neck, the local control is good, the regional control not so good, the leak rate pretty low, and the morbidity pretty low. And as you go through these others, you can see that there's improvements in the regional control with increases in the morbidity. The number one complication from esophageal surgery, no matter what kind you choose, is pneumonia from aspiration. And it's generally from dinging the recurrent laryngeal nerve. It's not, from all the breaking of the barriers. I mean, it is partly due to that, but, we're draining the stomach, so that shouldn't be a huge issue. But it's because the recurrent laryngeal nerve is often dinged at the time, and if that happens, then patients are unable to get a very strong cough, and that leads to pneumonia. So they just have very poor pulmonary toilet to follow. So preserving that recurrent laryngeal nerve is really, really critical, and something that everybody should try to do anytime they're touching the esophagus. But if it's dinged, which it is often, pneumonia is going to be your number one complication. Thoracic duct leak is not uncommon, especially in the more aggressive regional control operations. You're going to treat those like you would any other fistula kind of leak. The higher it is, the more likely you're going to have to go to the operating room and just fix it. The lower it is, the more likely you're going to be able to treat it conservatively. When you need to go in, no matter where you've operated in the chest, we always go in on the right side to go ahead and control the thoracic duct on the right. So it would always be a right VATS or a right thoracotomy to go in and fix that thoracic duct. You're not going to fiddle around and try to figure out where it's coming from. Arrhythmias are less common now because of beta blocker use. Graft ischemia is not so common either because we have better techniques to control blood pressure lability intra and post-operatively. But it's more common in the more aggressive operations. And then finally, graft necrosis, not very common, but you're going to go back to the operating room immediately to remove it. So again, it's choosing the surgical approach. If you have a tumor in the neck, you're probably going to need to do a 3-hole. If you need good local or regional control, you're probably going to do either an Ivor-Lewis or a 3-hole. If you need a wide local margin, you're going to choose an Ivor-Lewis or a 3-hole. And if you need to confirm lymph node status, you're going to look to see where those lymph nodes are going to be. Like if it's all distal esophagus, you can do a transhiatal, no problem, which is where most of the esophageal tumors are.